you brought up Carfilzomib as an option. What do people think about that? There's some pretty exciting looking data with Carfilzomib in the frontline setting. Does anybody want to take a shot at telling us about what that looks like? And Bill?
Sure, I'll do it. So there is data from mainly one center using a combination of Carfilzomib, lenalidomide, and dexamethasone. A lot of treatment, up to 18 to 24 months of treatment, and also combining it with a stem cell transplant. But those patients that they had treated and reported on have achieved very high rates of complete response, stringent complete response rates above 85% for these patients. So the data looks promising, but I would still say it's preliminary and it needs to be validated by other groups and larger numbers of patients. And it's worth pointing out that even though NCCN guidelines allow the use of Carfilzomib as upfront therapy, it doesn't have an FDA label for that.
Has people found that a challenge if they've tried to use Carfilzomib in a patient?
So that's a great question. So I mean, I think for us, we've used now for a newly diagnosed patient that comes in MD Anderson, I think the two options that we'll typically consider is a bortezomib Lendex combination. And now we're actually transitioning to more and more Carfilzomib Lendex patients, again, based on two things. One, that we've proven that 3 drugs is better than 2. Number 2, we know that depth of response matters. So sticking with that oncologic principle, that depth of response matters. And that we know that when we look at Carfilzomib-based therapies, we're getting to deeper, and more patients getting to deeper remissions in MRD that we've ever gotten before. So again, sticking with the oncologic principles helps me say that we can use Carfilzomib Lendex in that setting. And again, also extrapolating from the Endeavor data where we showed that Carfilzomib had a better depth of response and duration of response and a doubling of the CR rate and PFS. So I'm using that to extrapolate into the frontline setting, saying using my oncologic principles helps me use this combination now.
So given that this is not yet approved by the FDA for frontline use, Bill, you're on the fence a bit, VRD versus KRD. It sounds like MD Anderson's transitioning a bit to KRD. What about you, Ola? What are you doing at Sloan Kettering?
Well, as you know, we have worked on this combination since 2010. I think I personally treated more than 200 patients with this combination. So I feel comfortable using it. It is NCC approved. We have actually implemented that as our default therapy at Memorial Sloan Kettering. We give 6 cycles of
Have you done any challenges getting the drug approved by given its?
I think we have set the stage, so we no longer really have those. We had those problems in the beginning, but now that has become our standard of care for Memorial. We give 6 cycles.
Ola, what dose of Carfilzomib do you use?
That's a very important question. So we give 20 milligrams day 1 and day 2.
Squared.
Yeah, per meter square. 20 milligrams per meter square day 1, 2, and then we jack up to 36 milligrams per meter square for every subsequent dose, 8, 9, 15, 16, and for the subsequent cycles.
Some people have said the issue with using Carfilzomib in the frontline setting is these are rare but important toxicity profile. Have you had any? What has your own personal experience been with that?
So the reported issues people have talked about a lot is that could be cardiac signal, that could be maybe renal signal. But the Aspire trial that you led, Keith, you showed that there was no difference in cardiac adverse events in the randomized trial.
There was a difference. It was just there were small.
A small difference.
Yeah.
So
small percentages. The actual difference is double the number of events, but it's 2% versus 4%.
So in my experience, I've probably, as I mentioned, treated 200-300 patients with this combination. I probably have seen 2 or 3 cardiac events.
1%.
So that's relatively low.
You feel comfortable
I feel
using
very
this drug
comfortable.
in the front
Yeah,
line
I do.
setting. Rafael, what's your thinking?
I don't want to sound like I'm the most conservative in this stance, but I do actually like I do like the VRD combination for upfront, and particularly because I agree with the principle. We put the best players up front. But for the first half, I would put VRD. For the second half of the game, I would put KRD. And the reason for that is the data with Aspire, which you would agree with, is quite spectacular. When we look at the first relapse, our ability to induce complete responses is very, very high. And I think we're fortunate, it's not a good word, but fortunate we can discuss this minutiae of the toxicities, because I think VRD followed by stem cell transplant remains a very powerful combination. And again, I think this is temporary, because just down the line, whether it's months or years from now, we'll start seeing blank monoclonal plus VRD or something
Yeah,
else.
so you brought up monoclonals. I don't want to spend a lot of time on it because we'll come back to these, but is that the future? Are we going to be using triplets plus a monoclonal? Can we afford it? Don't answer that last question, just the first one.
Okay. Go ahead, Bill.
That's a very good question. I mean, I think the availability of monoclonal antibodies that target myeloma cells is really a new frontier for us, because these have a totally different mechanism of action, and we believe, and I think there's data emerging, that they're going to be synergistic with many of the other frontline drugs we use. So I think it's inevitable they're going to move into the front line. Now, whether it's a 3-drug monoclonal or a 4-drug monoclonal, there's cost considerations and potential toxicity situations that need to be seen, but I think it's the future.
So if I just make a comment real quick,
Yeah,
I
please.
think based again on the oncologic principles, yes, I do think that your best therapies are going to move up front. But I just want to actually comment a little bit more on what Ola was talking about the side effect and toxicity
Sure,
profile,
please.
if you don't mind.
No, I don't mind at all.
So I think that I want to change the conversation a little bit and go a little bit beyond just talking about the percent of cardiac toxicity that we see. And I think it's important to get a little bit more clinical perspective on that. And so from what I've seen, the patients that have had cardiac toxicity, you recognize it, you stop it, but then within several months, their symptoms resolves and their ejection fraction comes back up
Yep.
to normal. So I think that's important, not just say that they get this at a low incidence or doubling the rate, but the clinical relevance of that in the long term. Short term, yes, but long term, these are patients that are necessarily in the hospital, in the cardiac ICU. They have symptoms, you stop therapy, you manage it, and several months later they recover, which I think is important kind of to
That's
complete
been
the
our
story.
experience too. So I think the message is monitor. You don't need to do baseline testing, I don't think. Monitor be aware of that side effect, stop the drug. It does usually
Is
improve.
it possible to reuse the drug in those patients?
So
Well, I think you'd be a bold person to do that, but
Well, we don't even have the publications of the natural history. We're working on that
Yeah.
to know what the reversibility is. I think our, gestalt is that it recovers,
All right.
and it may be a price to be paid for effective proteasomal
let
inhibition.
me. I don't want to dwell on this right now. We'll come back to because we have the relapse trials to look at. So I think the summary here is that use your best drugs at the beginning. Use a triplet therapy. Most people around the table say it's a proteasome inhibitor and an immune modulator. If you're outside the US, that means probably thalidomide and bortezomib. Here we're seeing a transition from bortezomib, lenalidomide, dexamethasone to carfilzomib, lenalidomide, dexamethasone, gradually happening, it looks like. So an ixazomib in this population we don't think is, well, we'll talk about that in a minute when we come to the more elderly patient, but I didn't get a lot of enthusiasm for that in the newly diagnosed younger patient. Let's talk about